everyone. So in this video we'll study about headache and some autoimmune disease in the neurology topic. So we can start with headache. So headache, we can see the pain which is located in head, neck and jaw, and it can be primary headache as well as a secondary headache. Primary headache mainly includes migraine, cluster and tension headache. And secondary headache occurs secondary to intracranial hemorrhage, brain tumor, meningitis, any temporal arteritis or glaucoma. Okay, it's secondary to any disease, and the primary headaches, the cause is there in the brain itself. So let's start with the primary headache. So in case okay, we can also start with the how can we or what we should do, or how can we know about what kind of headache it is. So whenever there is a person who's coming with a complaint of headache, you have to see what is the seriousness and the severity of that, and what is the history and physical examination coordinating with the or telling about the current complaint. So is it the first episode of the headache, or there has been multiple episodes and there is a history of recurrent symptoms, like in primary headache you will see in migraine there will be history of some 3 days the headache remains, and there are some associated symptoms with it, or there is band like headache and tension headache all over throughout the day and occurs many times, and you have some stressor in your life. So or to see the secondary causes, if the headache is with some fever and nuchal rigidity, you can go for the meningitis. If the patient is saying I have the worst headache of my life and it's like a thunderclap in the onset and there is some nuchal rigidity associated but no fever, we can think of subarachnoid hemorrhage, any intracranial hemorrhage. And if the headache is very dull but it is deep and it's aching and it's not letting you sleep and it's not getting treated with analgesics, so it can be due to brain tumor. We can do MRI and check for the pathology given other signs are present. Or there is history of vomiting that is occurring before headache, and or the headache is induced by coughing or the lifting or bending, or these all things they will suggest us for the posterior fossa brain tumor in case. So and if other symptoms like unilateral pounding headache with some visual changes, and it can be dull and boring with some lancinating pain, and the patient you is saying is female, more than 50, has other symptoms like polymyalgia rheumatica, some jaw claudication, fever, weight loss, tenderness in the scalp, and ESR is raised, and so that can be due to temporal arteritis. For that you can do biopsy of the temporal artery, and you should initiate the steroid therapy with before the getting the results of the biopsy. And there is if there is a history of eye pain, you can see the mid dilated pupil, or and there is a history, so we can go for glaucoma also, that the diagnosis can be glaucoma with eye pain preceding the onset of headache. And like this we'll do all the history and examination, then lab diagnosis and some imaging. These all help us to come to a diagnosis, and then when we manage the patient accordingly. So first of all, migraine headache, very common, let's go with it. So migraine headache is mainly benign, it is recurrent, and it is associated with headache, nausea, vomiting and other varying neurological dysfunction. So it is mostly pulsatile, throbbing, unilateral, aggravated by the minor movement. With it can be present with photophobia, with phonophobia. Photo is with light, exaggerated with light, and with phonophobia is with loud sounds. And there is, pain occurs around window 4 to 72 hours, and there is some triggers to the pain, typical trigger, and that differs with every individual. Something like alcohol, chocolates, cheese, some MSG, that is monosodium glutamate, or hunger, or irregular sleep patterns. So this migraine we can divide based on aura, without aura, with aura, and no aura, without aura. So with aura is we call classical, but without aura is more common. So in this there is no preceding focal neurological deficit we can see, but migraine with aura is a classical migraine, and it is accompanied by a aura. It can consist of the aura, motor, sensory, or visual symptoms, and the focal neurological symptoms can occur during the headache. And the classical thing is, the patient says about the scintillating scotoma, the brightening lights that they can visualize, and there is visual auras with stars, sparks, and flashes of light. There is focal neurological symptoms, and that we can see, but there is no classical complaints, of vomiting, headache, and nausea. So complicated migraine is migraine with severe neurological deficits that persist after the resolution of the pain. And the basilar migraine is migraine which is associated with symptoms which are consistent with the brainstem involvement, like vertigo, diplopia, ataxia, and dysarthria. So all this vertigo sensation, diplopia, we'll see double images, formation, ataxia, unable to maintain your posture, and dysarthria. Okay, so this is what migraine headache is, and we'll do neuropharmacology. In that we'll discuss about the specific treatment, like triptans and other CGRP antagonists, or the antibodies that have come, erenumab, that have come now. And so we'll discuss about the mechanism of action and all those. So let's go now to the tension headache. So tension headache is very light and band-like headache. It occurs bilateral, band-like, and it is associated with tightness of the neck muscles, and the pain is building slowly for several days with or without fluctuation, and it's not associated with exaggeration with any movements. So there may be a stressor, known stressor in the life. If we see ask the patient's history, we can see for the stressor. So accordingly we give painkillers and psychotherapy if required, psychiatrist intervention if required due to any specific stressor. So accordingly we treat according to the etiology. Now cluster headache mainly occurs in males, and it is excruciating unilateral periorbital pain, like this is a male, so it will be tearing, unilateral tearing of the eye, and there will be periorbital pain, and it's not pulsatile, but intensity is very high intensity within the 5 minutes, and it can last from 30 minutes to 3 hours an episode, and multiple episodes occur in a day, and it goes on till 4 to 8 weeks. So symptoms, I've already told you, rhinorrhea from the nose also, there is congestion, reddening of the eye, lacrimation, nasal stuffiness, and the patient is sensitive to alcohol, and you can see Horner syndrome also sometimes associated with it, and there is no specific trigger to it, and so that is how we can diagnose the cluster headache and with the symptoms. So if we see all together all the headaches and their treatment, so migraine headache, if if in short we see migraine headache, if there is an acute episode, what we have to give the abortive therapy to abort it. So we give triptans, sumatriptans, which is the first line drug. These are the serotonin receptor agonist. They act on 5-HT1B 1D receptor of serotonin, and others ergotamine, they are used with combination with caffeine for acute abortive therapy. But they have ergotamine, is very highly vasoconstrictive and can cause some very severe side effects. So we usually go with the triptans. Other like dopamine antagonists like metoclopramide can be given to help with the nausea symptoms too. And prophylaxis, CGRP, monoclonal antibodies acting on CGRP, that is calcitonin gene related protein. Okay, so it's responsible for the inflammation of trigeminal nerve that causes the migraine. So the antibody acting on it, adalimumab, so that prevents the inflammation and hence the migraine. Now for prophylaxis, we give beta blocker like propranolol. Topiramate also we give, which is anti-epileptic drug. And topiramate, you also know the one specific thing, it is the only anti-epileptic drug that causes weight loss. And then there other we can use is valproate and verapamil and tricyclic antidepressant we can use in it, and SSRIs like sertraline or fluoxetine we can use. So these are the prophylaxis they ask. So prophylactic drugs, they usually ask all the prophylactic drugs that can be given in the question. So beta blockers, calcium blockers, TCAs, SSRIs, valproate and topiramate. Now tension headache, you will give, say there is a tension in the neck muscles, you will give relaxation techniques, massages, and you can give analgesics like NSAIDs, acetaminophen, and you can also add muscle relaxant if the patient still has a lot of spasticity in its muscles and tension. Cluster headache, the acute episode, we go with 100% oxygen, and we can for the prophylaxis we go with the verapamil, that is and prednisolone can also be given, or lithium can also be given, but verapamil is main for the prophylaxis. Now for something that we have to take care is sometimes we have to give opioid analgesics. So in that case, in a very rare case where there is refractory pain, so we have to take care that there is no addiction developed with it, and we have to carefully monitor the drugstore also, the pharmacy from where the patient is procuring the opioid analgesics. And like methyl sergide also we sometimes use, so it has a serious side effect of valvular and retroperitoneal fibrosis, so we have to keep in mind that also. So now there is something also I want to discuss, which is pseudo tumor cerebri, which is a benign intracranial hypertension, and it is idiopathic, and the idiopathic increase in the intracranial pressure, and women mostly have it more than men, 10 times, and there is a association with obesity, chronic lung disease, Addison disease, OCP use, tetracycline drugs, and vitamin A toxicity. So we have all seen these kind of questions. They'll mention any one of the factor as a etiology, and it will be pseudotumor cerebri, the diagnosis. So it will present as what? Intracranial pressure. See, I told you one formula, cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. So if this is increased, first of all we have to decrease this, and we have to maintain the balance between both sides. Okay, so what will give first of all, how it will present. So increase intracranial pressure, so there will be headache, there will be visual disturbance like papilledema, and optic disc swelling, that is papilledema. In papilledema you'll see the blind spot is enlarged, and there is sixth nerve palsy. We'll see sixth nerve supplies the lateral rectus, so there will be no abduction because lateral rectus will be paralyzed. And if you do the lumbar puncture, you will see increase opening pressure, and otherwise the MRI and CT will be normal. And treatment is mainly with what we'll do removal of the offending agent if there is OCP use, and in urgent we'll give diuretics, acetazolamide, and we'll use prednisolone. And for very urgent cases we can repeat serial lumbar punctures to decrease the CSF volume and decrease the effect. And we can also, in case there is no relief with any of the treatment, we can go for the shunt between ventricles and peritoneum, ventriculoperitoneal shunts. So the ventricles excess fluid will be drained into the peritoneum, so that also can be done, but that is in very rare cases, not. And now other thing that we have to discuss is trigeminal neuralgia, which is an idiopathic pain syndrome. The word idiopathic, the cause is not known. And so the idiopathic pain, and it causes the sudden sharp pain near the side of the mouth, which progress to ear, eye and nostrils. So these attacks are severe, and they are triggered by like simple touch, talking, eating or brushing, and there is something cold sensation, and the pain lasts for a few seconds and then disappears. But the pain that occurs is very severe. The severity is very high, and it is very debilitating or incapacitating for the patient, and they are not able to bear the pain. And it occurs due to the compression of this trigeminal nerves. That's why trigeminal neuralgia. Trigeminal nerve root is compressed by a blood vessels, and that causes the pain. And it can be due to multiple sclerosis or posterior fossa tumor. And only treatment that we give for it is carbamazepine, which is standard of care. And if there is no response, we try phenytoin, baclofen and gabapentin. And if there is still no response with the medical treatment, we go for the radiofrequency ablation of the affected nerve, and it's removed surgically. So that was mainly about all the headaches. Now we can go to some autoimmune disorders like multiple sclerosis. So multiple sclerosis, we know, is an autoimmune inflammatory disorder of CNS, white matter, and it is a relapsing and progressive mostly. And the cause can be many. It can be genetic, it can be environmental with infection, dietary, or it can be due to your place where you belong, demographics, like more in North European descent. And so what will the patient present in the multiple sclerosis? Mainly with a weakness and numbness or tingling or unsteadiness of the limb. There will be urinary urgency or retention. In the eye symptoms, there will be double vision or blurry vision. And if we see pathologically what is happening in this case is there is focal demyelination that is occurring. This is a nerve with myelin sheath, so there is demyelination of the nerves in many areas. Okay, and it can be relapsing remitting type. relapse and remit. So the progression we mainly characterize by the relapse of active disease with incomplete recovery during the periods of remission. And then there is secondary progressive, that is the progression will become more aggressive so that the consistent worsening of the patient is occurring. And something like primary progressive, directly the symptoms are progressing from the onset of disease with early onset of disability. And so these are the different how they present, like that's how it's divided into, like primary progressive, first, then secondary progressive, or there is relapsing, remission, and then again relapse. So it can be like this. Now what we have to see about MS is, to diagnose the MS we have clinical criteria, and we have some laboratory confirmation and radiological confirmation. So if the patient is coming to you with multiple neurological complaints that we cannot explain by a single CNS lesion, and we can see multiple neurological deficits that are separated by time and space, that is space here is with anatomy in context of. So what we'll do the most accurate is MRI of the brain, and there will be increased T2 and decreased T1 intensity. That will represent the increased water content of the demyelinated plaques in the cerebrum and the spine. And if we do gadolinium contrast, so the lesion will enhance, so that enhancement will tell us about the active MS lesion. And we can see the evoked response potential, that we can see it will detect the slow or abnormal conduction in response to visual, auditory, or somatosensory stimuli that we use. And if we see CSF analysis, we see pleocytosis, that is less than 50 cells per microliter, and total protein that is mildly elevated. And we can see IgG index, that we say as orange colored oligoclonal bands that are seen in 90% of patient. So CSF for oligoclonal banding, we only do it for when we have to reconfirm it after an MRI, and MRI is not confirmatory for MS, and we have the clinical suspicion for it. So the best initial test is, and the most sensitive test is MRI, brain and spine. Okay. So, and CSF analysis, mild pleocytosis and mildly elevated total protein. And how we'll treat it then? The main pathology is demyelination, focal demyelination, that is occurring at different times and at different places. That is the meaning of separated by time and the space. And those demyelinations and the nerve degeneration, that is causing the various neurological deficits that we are seeing. So what we'll treat it with? So treatment is mainly with the disease modifying therapy, that is like interferon, beta 1a, beta 1b. We call glatiramer acetate, that is used for relapsing and remitting disease, because it decreases the number of clinical exacerbations, decrease the MRI activity, and it delays the significant disability. And for the primary progressive disease, which is primary progressive, there is no disease modifying treatment for that. And for secondary progressive, we go for the interferon beta 1b and metozentron, other drugs like methotrexate, metozentron, or immunomodulators like cyclophosphamide, IVIG, IV immunoglobulin, that is, or azathioprine, only if the patient is with relapsing, remitting, or secondary progressive disease. and they are unable to tolerate the interferon and the glatiramer acetate. But and the side effect of these metozentron is mainly cardiotoxicity, that to dose related. So it is only given to those people who have normal ejection fraction. Also we can you know natalizumab, that is associated with PMLE, so that's why we try not to use it. And ACTH we no longer use for this. And the complications that have to be treated, like we have to give steroids for it, IV steroids for 3 days, then we follow it with oral steroids and taper it over the next 4 weeks. And if there is no response and disease is severe, we go for the plasma exchange. And like for a symptomatic treatment, that is like spasticity, we give baclofen, tizanidine. And for carbamazepine and gabapentin, pregabalin, TCAs are for the pain that is occurring due to various dysthesias or secondary to demyelination. And oxybutynin we can give in the bladder hyperactivity. And you remember the bladder oxybutynin acts on beta 3 receptor on the bladder wall. And bethanicol for the urinary retention we can give, and amantadine for the fatigue, and sildenafil if there is an erectile dysfunction in male because of it. And one drug that has been used is delphamidine, which is an oral disease modifying medication that has increased the walking speed. So it is a potassium channel blocker for which the precise mechanism of action is not yet clearly known, but it is a good drug. Another drug is fingolimod, that decreases the rate of disease that we can see with the MRI progression. It decreases, so it prevents the lymphocyte from proliferating outside of lymph nodes, so they won't act on the myelin and deplete it. And but the side effect of this fingolimod is again cardiotoxicity, like metozentron, so that's why we have to be very aware of it. Next autoimmune disease important is myasthenia gravis, neuromuscular junction disease. And it is the first disease that we studied in the autonomic nervous system, so in the pharmacology. So it is mainly characterized by weakness and fatigability. Of course there is less activity of the acetylcholine receptors, because the antibodies are against them and the receptors are destroyed, so acetylcholine is not able to act, and that leads to the weakness. And that's why it's autoimmune, because acetylcholine receptor antibodies cause decreased number of active and functional acetylcholine receptors at the postsynaptic membrane. We know here the acetylcholine receptors, acetylcholine released by the nerve terminal here, but these are depleted, so it's not able to act. Now how it will present is mainly with muscle weakness and fatigability. Earlier signs will include mainly the patient has diplopia, tossers, difficulty swallowing, and with a mushy or nasal quality of voice. And in later disease it will be more, the weakness will be more in the proximal muscles in a very asymmetric pattern. The deep tendon reflexes are mainly intact, pupillary responses are normal. And in very severe cases, when it occurs early, late and very severe, is with muscle of respiration are paralyzed, and they're not paralyzed, means they won't be active because the action is not taking place, so they can undergo degradation or disuse, and the patient can go into impending respiratory failure. So that is very myasthenia emergency that we have to treat very urgently with plasmapheresis and with IVIG. And diagnosis mainly we do with acetylcholine receptor antibody test. so that will be positive mostly. And these antibodies are not in all but in 70% of the disease. And other test is adrophonium test. So adrophonium test is mainly sensitive but not very specific to it. So the patient may experience nausea, fasciculation, syncope, and bradycardia, which are all the cholinergic symptoms due to adrophonium. So that's why not very good or patient friendly. So we do X-ray in chest, because chest CT chest will show thymoma that we see in 10 to 15% patient, and this thymoma is where the antibodies are being made. And we can see thymic hyperplasia in 65% of people. And electromyogram is the most accurate one, electromyography. And in this we see decremental response or decreasing in the muscle fiber contraction if we repetitively give nerve stimulation. There is decremental response, decreasing response on the repeated nerve stimulation in the muscle fiber contraction. So it is also called very repetitive nerve stimulation test also, that is also very specific. Now treatment, what you will give? You will give the anticholinesterase medication, because anticholinesterase will prevent breakdown of acetylcholine in the synaptic vesicles. So increased acetylcholine will be ensuring more drug concentration is there. So the receptors which are okay, they can act in high concentration, they will be able to bind and act upon it. So those are pyridostigmine and neostigmine. Pyridostigmine we prefer because it is longer lasting. And if there is no response to anticholinesterase enzyme inhibitors, we can go for thymectomy in case of thymoma people. And we don't do it in very old or early age kids. And other thing that we can go for is plasmapheresis and IVIG for rapid effect, and especially in the acute myasthenia crisis we go for them, as I told you. And glucocorticoids are given for 1 to 3 months for clinical benefit. And steroids are the initial immunosuppressive of choice, because they are the conventional therapy that has to be given. So we can add azathioprine in it or cyclophosphamide to prevent the relapse in cases it has improved with the steroid, plasma exchange, and IVIG. And mycophenolate as the new immunosuppressive drug has fewer side effects than the steroid and cyclophosphamide. So this was the main thing in the myasthenia gravis. We also know this its friend Lambert-Eaton syndrome. In this, the calcium channel in the presynaptic nerve terminal are defective. So it is what it will show, the response will be same. There will be weakness because there will be no neuromuscular junction transmission. So in this we can differentiate it with myasthenia gravis by repetitive nerve stimulation and seeing the muscle contraction frequency. So with repetitive nerve stimulation it will increase, it will be incremental response, because the more calcium channels will be open and the acetylcholine will act on the postsynaptic receptors, and the muscle will act and contract accordingly. So with more stimulation it will be incremental response. So it may be electromyogram, same, we do repetitive nerve stimulation test. And there are some associated autoimmune disease that also have similar etiology, that looks like similar etiology, because like GBS is there, like Guillain-Barré syndrome, in which there is severe polyradiculopathy. Poly means multiple, radical, the roots are involved, and it's an autoimmune destruction of the myelin. And etiology is mainly autoimmune that we know, and body's immune system starts to act self-antigen. It thinks self-antigen as a foreign antigen. That is a phenomenon called molecular mimicry that occurs in most of the case. It is post Campylobacter jejuni infection, that is a GI tract and respiratory tract infection that occurs. So post this infection, 1 to 3 weeks after, we see the GBS syndrome symptoms starts to occur, because the body think of its antigen as self myelin to mimic the same antigen as its one, and they start to act against self myelin also and cause myelin destruction like C. jejuni, and this molecular mimicry again. So this leads to the demyelination and the symptoms. So it mainly presents with the rapidly developing weakness in lower extremities and start moving upwards. So it is ascending weakness that we can see, and other things like it will be poor reflexes. The reflexes will be poor, and sensory disturbance like tingling dysthesias can be there. And in severe, if it is very severe, so autonomic instability we can see, like profuse sweating or hypotension. And so how we'll diagnose it? Mainly we'll recognize the pattern of weakness, and along with the absence of the reflexes, fever and constitutional symptoms. There will be history of any GI infection previously in some weeks before, and lumbar puncture and cell count. Lumbar puncture for the cell count and protein is also a good test, in which we can see there will be rise in cell count on CSF and elevated protein. It was wrong. The CSF, in what I said, it was sorry for that. In CSF, what we'll see, there will be elevated protein with no increase in cell count. Cell count will be normal. Okay, so that is important. And this most accurate test again for this is electromyography, that will help to detect the evidence of demyelination in the peripheral nerves. Treatment is also same, IVIG and plasmapheresis or plasma exchange. And glucocorticoids are not as effective as in the other autoimmune disorders, and IVIG is a good treatment that shows results along with the plasmapheresis. So these were the autoimmune disorders, some of them